Good evening, everyone. I am Deepak Vora, Marketing Head of Invencia, a division of Emcure, and being a consistent partner of all the gynecologists and being the number one knowledge partner of gynecologists, it gives me immense pleasure to welcome all of you to have this wonderful webinar and a chat show with interesting content on pregnancy and how we find the challenges related to anemia with injectable irons in pregnancy. Today, we are going to have a wonderful session because we have distinguished guests as well as prominent speakers who are not just going to present their views, but also going to interact and discuss on various aspects of handling difficult situations in pregnancy, particularly with focus on anemia. So this has been possible with our partnership with ISOPAR and a leading society which is always there at the forefront of not just providing the international content as well as platform for all the gynecologists to interact and enrich and continue the fight in the journey towards bringing the best in women's wellness. So we have distinguished guests from ISOPAR, and to take it ahead, I handed the session to Dr. Shobha Ngudi, who is Chairperson Committee for Contraception and Reproduction Division of ISOPAR. Over to Shobha ma'am. Shobha ma'am does not need any introduction in gynecology. She has multiple publications as well as a great deal of work with regard to various academic work, and ma'am has been instrumental in bringing this program ahead, and she has been associated with various academic programs with related to gynecology, and she is currently professor and HOD at Philomena's Hospital, Bangalore.
Thank you.
Yes.
Thank you, Mr. Vora. Thanks a lot for that introduction.
Yes.
And I welcome you all to this webinar on the management of severe anemia, something which we regretfully, even today, we encounter severe anemia and we are adept at handling it. But just to sit together for a chat and to find out the best ways, the safest ways possible to take our women across this bridge of ill health and go to the other side where they have a normal hemoglobin and normal health during their reproductive lives. So to begin with, let us seek the blessings of the Almighty. Can we have the prayer? Can the provider give the prayer, please? Play the prayer song.
Vakratunda Mahakaya Suryakoti Samaprabha
Slides did not move.
Nirvignam Kuru Me Deva Karyeshu Sarvada.
Okay, if there is a problem there.
Yeah, ma'am, it is playing. Somehow we are not going the voice, so he's just replaying it again.
Okay.
Just a minute.
Since it's the Almighty, there is always. Yeah, thank you.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
Nirvignam Kuru Me Deva Sarvakaryeshu
सूर्यकोटिः समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Yeah, thank you very much. It is now my privilege to invite Dr. Arup Kumar Majhi and Dr. Pragya Mishra Chaudhary. Due to some emergency, Dr. Pragya will not be joining us. So it is my privilege to introduce Dr. Arup very, very briefly, because in the ISOPAB, circles, Sir does not need any introduction. He has been the president for the past few months, and already there is a lot of work which has been done under his leadership. Sir is Professor, Shanti Niketan Medical College, Bolpur, Birbhum, West Bengal. Has authored several chapters, including the bedside clinics in obstetrics and gynecology. And he has also worked in the past in Ajikar Medical College. Sir has been the president of the very prestigious Bengal Obs and Gynae Society, and we all witnessed what that society can achieve in the AICOG last year, and Sir was integral part of the organizing committee of that conference. And also, as I said, he was the scientific committee co-chairperson. More than 30 years of teaching experience, and editor of the Indian Journal of Perinatology and Reproductive Biology, and past national corresponding editor of Jogi. Sir, can we request you to say a few words on the subject matter of today? Thank you very much, sir, for being here. Yeah, you can stop the screen share.
Thank you.
Please
thank
stop
you,
the
Dr.
share. Stop the screen share. Provider, host. Thank you. Yeah.
Thank you, Dr. Shubha. Very good evening, everyone. Dr. Meena
Good evening.
Very good evening. I think Dr. Pragya is not joining.
She has some
Secretary
emergency.
General.
Yeah.
And I am seeing Dr. Reena Awani. So this is a very important seminar today. It is organized by the ISOPAR Committee of the Contraception and Reproductive Health. The chairperson is none other than the Dr. Shobha Gudi. Very enthusiastic and dynamic, because only 1 month back you have done a very good webinar on, I can remember, on the 14th September. That is on the non-communicable disease and diabetes. Diabetes. Only NCDs, 1 month and back. And after the quick succession after the EICOG, thank you for organizing so important seminar today on the positioning parenteral therapy in managing severe anemia in contemporary obstetrics gynae practice. And so regarding the anemia, everything knows everything. Everything knows everything. Am I audible? Am I audible?
Yes, sir. Yes, sir.
Okay. So everything knows everything about the anemia. That the prevalence of anemia in the developing is very high. It is more than 50%. WHO estimates that 40% of the pregnant women globally have anemia, associated with significantly increased risk of maternal and perinatal morbidity and mortality. In India, 50% prevalence in vulnerable groups, not only for the pregnant women, among the pregnant women, but also in the infants, young children, and the adolescents. And it is also estimated that in 20% of the maternal death, anemia is the underlying cause, directly or indirectly in any way. And 20% of the pregnant women had less than 8 gram% of the hemoglobin in India. And 2 to 7% of the women have a value of less than 7 gram%, that they suffer from the severe anemia, and which is aggravated during the labor and also postpartum, and during the puerperium, resulting severe complications both for the mother and the baby. And iron deficiency is the commonest cause of the anemia during pregnancy. And Government of India in the National Health Mission program has published in Anemia Mukt Bharat operational guidelines, then recommended. It was passed in 2018, and in that guideline it was clearly for prevention of anemia, 6 months of iron during the pregnancy period, another 6 months after the pregnancy period. They recommend it. And also, as there is hookah manifestation and more in India, so the India government also recommended for the and health in the second trimester. The advantage is at least one dose. And government of India, all that guideline also, particularly they have specified in which setup and what is the in which type of anemia how treatment will be given. And this setup is also when the oral therapy is given, when the parenteral therapy is given. And though oral administration is the primary mode of treatment and the preferred method, but there are clear-cut indications of the parenteral iron therapy. And so that is also guided by the government of India, how can, particularly when the patient comes in moderate and severe anemia with anemia, and also the postpartum mother, there is the non-compliance and also the intolerance of the iron. And we do not know whether the patient is taking or not. And sometimes it has been found in spite of the oral therapy, the iron and the hemoglobin is rising. So there are some clear-cut guideline and indications. So in this perspective, we are very fortunate to hear from our faculty, particularly Dr. Shobha Gudi, who will speak on the know your molecule ferric carboxymaltase, and also the discussion of the clinical application of the parenteral iron therapy. Today, I think it will be very valuable input for all of us, and also the esteemed isoparpians and all who have joined here. The today our experts are Dr. Mala Arora, who is the VP Foxy, past VP Foxy 2011, Dr. Reena Wani, and Dr. Uma Ram, and Dr. Meena Samanto, who is our Vice President Isopar, and Dr. Pradeep Rangappa. So we expect and we also hope there is a very, very good webinar. And today, thank you, Dr. Shobha again.
Thank you, sir.
And we want to hear from future also. So long live Isopar, long live Isopar, long live Isopar. Thank you.
Thank you, sir. Thank you very much, sir. So I request the host to share the screen and give me the CVs of the experts. And once I bring them on the dais, the virtual dais, I will give a brief presentation. And after that, we will open the floor for discussion, primarily with the experts, and a very welcome interaction from the audience. And that is the reason why the platform has been kept open, because we want consensus. So Dr. Pradeep, by default, I think you have come first, the only gentleman amongst the ladies today. So welcome to Isopar and welcome to this discussion amongst audience.
Thank you, Dr.
Yeah, so you are an intensive care physician known to me for a very, very long time, because we work together for Manipal Hospital, Bangalore. In addition to Philomena's, I'm attached there also. Those are your degrees. What is more important is that you have served as National Vice President for Indian Society of Critical Care Medicine. Oh my God, I thought you are the president. And I think you will soon be. And of course, a lot of valuable service you have rendered as an intensive care physician at Manipal Hospital, Bangalore. So also, you have been the past secretary of ISCCM and other accreditations. Can I have Dr. Reena? I can see her CV next. Yeah, welcome, Dr. Reena. Go to the next CV, please. Yeah, slideshow. Any problem is there in sharing the slides? Please go to the next CV. Okay. I'm sorry. RX, please. Yeah. Deepak, please show the CVs in tandem. I'll finish all the introductions. Yeah. So Dr. Reena Wani, welcome. Reena, I'm so thankful that you were able to present here. We soon want to see you as the Vice President of Foxy in 1 or 2 years, if not immediately. You have rendered wonderful contribution as Foxy Perinatology Committee Chairperson in the past. You have done a great deal of work for breastfeeding promotion in MOX, and also in the core committee Violence Against Women. Of course, you are professor and head of the department of HPT. I'm sorry for this CV. It is an older one, I think. But you are currently heading the department at R.N. Cooper Hospital, HPT Medical College. So welcome here. A very prolific author and an editor of textbooks. I'm so grateful that you could make it today. Next, please. Next CV. Yeah. Thank you, Mala, for being here. You are, for whenever there is a reference to recurrent pregnancy loss, I think you are the favorite faculty. You have done so much work in that subject, but even otherwise, I think you are known as a very, very astute clinician and an ART, expert. Chief editor of World Clinics in Obs and Gynae. You have won awards for your work in the past. Of course, you were vice president of FOXI in 2011, and also notably the chairperson of ICOG in 2017. Peer reviewer for British Journal as well, and associated editor for International Journal of Infertility and Fetal Medicine. Welcome to our forum. Next, please. Can I have Dr. Uma Ram? Yes. Very dear friend, director and consultant OB-GYN, Sitapati Clinic and Hospital from Chennai. Very proud because she is also from South. Any which way, she has been the All India Chair for RCOG. I think just concluded or still at the end of her tenure as RCOG Chief. Examiner Part 3 MRCOG. And faculty maternal medicine gynec academy, coordinator perinatal mental health short course for obstetricians. Oh, I have always been wanting to do this course, Uma, and I'll take it up very shortly. Area of interest is of course GDM, fetal growth health awareness in women. And I didn't know that you loved music. Of course, travel and reading I could make out, but it is wonderful to know that you are also a lover of music. So I think with that, I can safely start my presentation. I have finished with the list of the experts, isn't it? Yes, I have Dr. Meena Samant. Dr. Pragya will not be able to join, but I must introduce formally Dr. Meena Samant, a very dear friend and currently holding the post of Dr. Pragya Mishra Chowdhury is the secretary, unable to join today. So we will take Madam's introduction in the next webinar when Madam is present. Consultant infertility specialist at New Life Test Tube Baby Center. But she quoted an emergency and she is not able to join. We are missing you, Pragya. Can I have the CV of Dr. Meena Samant? Dr. Meena Samant? I did see her CV initially. Okay, so I am sorry, Meena. I'll have to introduce you.
That's okay. That's okay.
Previous to this? Okay, I'm so sorry. Meena is a very dear friend, known to everybody. A lot of work has gone under Meena's belt as chairperson of the clinical research committee in FOXI. And I still remember because today's webinar is very apt for Meena as an expert because of the voluminous work she did for anemia during her tenure, especially for thalassemia. And for those of us who do not know, thalassemia is just lurking behind iron deficiency anemia many times. And, it is so elusive and many times it goes undiagnosed and results in further complications of anemia in the offspring, etc. And a trauma for the family as well. So Meena has done a lot of work there, has had several publications as chairperson. And what is very notable about Meena is her body language and her soft-spokenness. Very admirable. And as an academician, she comes across as somebody with a lot of knowledge, but ready to speak only when it is, extremely.
Thank you, Dr.
pertinent.
Shobha.
Thank you so much, Meena,
Thank
for
you.
being here. And in ISOPAB, you really have kind of helped me in so many things. Thank you. You are a pillar of ISOPAB, undoubtedly. So with that, with permission of everyone, let me, and I must thank Dr. Arup Maji and my dear friend, Dr. Pragya, for giving me the opportunity of conducting this, because I felt that it is very important that we sit together and we really established the role of intravenous iron. All of us have had, mixed experiences sometimes with parenteral therapy, but today I want to very firmly put this on board. So I will be very brief and I'll be very clinical. Parenteral iron therapy in pregnancy known to all of us. And we all stand informed that anemia is the commonest nutritional deficiency. It's the commonest non-communicable disease. And according to WHO, 40% of pregnant women are anemic in India. Even overall in the world, pregnancy anemia is fairly common. And this is from NFHS 5. I urge all clinicians to closely follow the National Fertility Health Survey data, because as we go through our day-to-day practice, it is very important to stay oriented to what is happening in the rest of the country. And NFHS is a very good way of finding out, especially for public health matters like anemia. Remember that anemia is a public health as well as a clinical health matter. NFHS gives very good data on that. And if you can see the third one, pregnant women 15 to 49 who are anemic less than 11 gram%, can you see that NFHS 4 was showing 50.4, and very dismally the urban India shows lesser than that. That is good, but in rural India it is 54%. So the total, the average is very unfortunately higher than what we had in NFHS 4. So actually the problem is still there. Problem has not been solved. The betterment in socioeconomic standard has resulted in maybe another type of malnutrition than what it was earlier. Well, we shall not dwell on this much, though in the total number of anemic women, OBS and gynae together are again higher than what was shown in the last one. So, okay. By definition, let us stick to the WHO, because I don't care much for differentiating first, second, and third trimester. We must have a hemoglobin percentage of 11 grams in pregnancy at all times. Less than that is anemia. And then even otherwise, non-pregnant women should have at least a hemoglobin of 11 gram%. So 11 is the magic number, though we prefer at all times that it should be 12 and above. But basic minimum is 11 gram%. And you can see that severe anemia in pregnant women less than 7 gram%, anything between 10 and 11 is mild, and moderate is 7 to 9. For practical purposes, we always say mild to moderate anemia, and anything less than 11, it is better to treat them aggressively, and less than 7, better to treat them in an emergency way. Okay, so here pregnant women again established cutoff. This table is showing pretty much the same thing. Okay, the classification of anemia, not to read out everything, but broadly, the 7 reasons why women become anemic in pregnancy and even otherwise are deficiencies. These deficiencies due to hemorrhagic reasons, which may be acute or chronic, hereditary reasons like hemoglobinopathies, etc., hemolytic reasons due to extrinsic and intrinsic causes, bone marrow problems, infections. So maybe infections should come a bit earlier, than hemolytic and hereditary, and like malaria, tuberculosis, and even other chronic infections. And then, of course, there is the chronic disease anemia, which is there, which also is comes to us in pregnancy, especially the renal component. So this is again a better way of looking at the condition. So here we need to understand that this slow blood loss due to gastrointestinal causes needs to be kept in mind, as well as pregnancy bleeding needs to be kept in mind. This is what I wanted to highlight here, because often we get to neglect that, and because they are all easily correctable, except when there is a malabsorption, and that can be a problem. So iron requirement of pregnancy is something that we are taught from our 3rd year MBBS onwards. We are taught that women require more iron in pregnancy. So what we need to understand is whatever we take in, the absorption is only going to be that much. So, this is how the pregnancy iron requirement builds up, because the fetus requires, the placenta requires, the red blood cell mass requires. Yes, this is what we have read. But what we need to understand that when we consume iron in our everyday diet, then suppose, we take in about 4 to 5 milligram per day of iron, only about 10% of that. That means hardly 1 milligram will be absorbed, whereas the requirement is up to 7 milligram. This is what we need to. That is why iron supplementation is very, very necessary. Otherwise, there is iron deficiency anemia, leading to these risks of prematurity, even of hypertensive disease in pregnancy, sometimes infections, or even heart failure in severe cases. The baby suffers due to prematurity primarily, maybe growth restriction, is more prone for infections like the mother. Neonatal anemia, cognitive development is of significant importance, because these children do not do well in schools, and yes, there is some risk of mental health disorders going on. Now, maternal anemia contributes to 18% of perinatal mortality and 20% to maternal mortality in South Asian countries, including India. These data may not be very fresh, but are fairly representative even now of what is going on, because anemia may not be the direct cause of death, but it may be an indirect cause and a contributory factor in many of the deaths that we see in our mothers. So the diagnosis is fairly simple if we have a good history and clinical examination. What is a little more complex is to exactly identify the degree of iron deficiency and to differentiate iron deficiency from other types of anemia. So there are few nuances, and only those we should see, because to the August audience, I don't want to discuss about the blood cell indices, etc. One thing to highlight here is that the low MCV and elevated red cell diameter width, red cell distribution width, this can be used as sufficient evidence to start iron therapy, because in thalassemia, the RDW is going to be low. Okay, so, but MCV is also low. So low MCV and elevated, if it is available RDW, the red cell distribution width, then you have a good reason to believe that there is, even without doing a ferritin level, you will know that there is iron deficiency anemia. There are other markers for iron deficiency, but they are not very accurate. Sometimes TIBC increases even in the absence of IDA, and serum iron has dependent on many factors, including intake of iron capsules. So diagnosing iron deficiency anemia in pregnancy at times can be a challenge. I just wanted to bring in this slide only one highlight, and that is the to differentiate again IDA from beta thalassemia trait, especially, and also the one thing was the reticulocyte hemoglobin content. That is another test which is useful, because it indicates good this measurement of not just the reticulocyte count, but early indicator of IDA and response to iron therapy can be made out by reticulocyte hemoglobin content. And the microcytic RBC percentage divided by the hypochromic RBC percentage, M bar H, okay, less than 3.7, also indicates the IDA from beta thalassemia trait, okay. So that these are the things which are important to note. And this particular one does not add to our diagnostic armamentarium. Only thing is, this helps us to understand that serum hepcidin may have a role very, very rarely, but it only indicates it is low in iron deficiency anemia, but in chronic anemia, it will be raised, and anemia of chronic disease. And the other thing is about ferritin here. Let us just look at ferritin in this slide. Iron deficiency less than 30, but when it is anemia manifesting, it has already become less than 12. So there is a huge window period when ferritin goes on reducing, compensating for the hemoglobin, but it does not reflect as anemia. By the time the woman is anemic, I think the ferritin levels are already very low. That is what we need to understand. Ferritin levels are raised in anemia of chronic disease. Whenever there is iron deficiency associated with chronic disease, it will reflect as less than 100. So we need to be careful about that. Now, the diagnosis of iron deficiency anemia in pregnancy is there any role of serum ferritin level? Many practitioners feel it is superfluous. Why to do an expensive investigation? If there is a known hemoglobinopathy, always remember that the woman may have an added iron deficiency, which is common. That this is what is peculiar to Indian women. They may be deficient in iron. They may also have a hemoglobinopathy. And do we give them iron therapy or not will depend on the serum ferritin level. If there is another etiology of microcytic anemia, like chronic inflammation or any toxicity with lead or sideroblastic anemia, then it is useful. And if oral iron, she is not responding and compliance is not very established, then, and if they are not anemic, but they have increased risk of iron depletion, like specific types of pregnancy, multiple pregnancy or teen pregnancy, or pregnancies with high risk of bleeding, like placenta accreta syndrome, etc., or very, very quick pregnancies. In all of them, even though the woman is not anemic, maybe sometimes it's better to check on the ferritin and know that she is at risk of rapidly deteriorating on the HB level when faced with a complication. After 8 weeks of therapeutic iron therapy, when non-anemia iron deficiency is being treated, and the serum ferritin will be less than 30 microgram without anemia. Preferably prior to parenteral to confirm iron deficiency is one school of thought, but of course we do not do. So serum ferritin does have a role, and investigation issues are that ferritin acts both as iron storage and acute phase protein. It cannot be used to evaluate iron status in the presence of inflammation. And if the CRP is also raised, then it comes to the soluble transferrin receptor concentration, since it is unaffected by. So these are other tests which can be used. So we need to carefully utilize our resources so that more is spent on the therapy rather than on investigation. I have put this slide for a particular reason, to easily understand, because I found it very easy to understand. This box here tells us the erythron iron, RBC iron. And you can see that with the depleting iron stores, here it is normal and this is also full. But when the iron stores are depleting, it still remains quite good. And you can see here plasma ferritin, the third row, less than 10, and that is when anemia is manifesting. The erythron iron becomes less. So the lesson learned again is the same. The peripheral smear becomes microcytic hypochromic due to iron deficiency. By then the stores are reasonably depleted. So this actually is a very good teaching slide so that our students, the younger generation, also understands this. The treatment, of course, diet, we need to understand. I think this aspect of treatment is more complex to understand than the molecules. I'm serious, because I think diet today is at risk, and it is very poorly understood in families, especially Indian families, where a lot of cooked food is used, serving the pregnant woman, and the importance of fresh vegetables, etc., and is not very well understood. So diet is a parallel which cannot be discussed in a segment like this. But I would just like to say that the dietary requirement of iron, calcium, etc., should be, and protein should be optimized, giving it a little more thought when there is anemia, because all factors are required for hemoglobin synthesis. So when it comes to iron supplementation, which is a must even in normal pregnancy, even in normal hemoglobin, it is important to understand which type of iron is better and which are the ones which are going to inhibit iron absorption, what is important in dietary modification, etc. The aim remains to correct the iron deficiency, to replenish the reserve, okay? And then treat the pregnancy otherwise. And the choice of therapy, of course, depends on the gestational age and the severity. This we all know. And these are the iron supplements, the oral ones, and we all use ascorbate very freely. It is a bivalent iron, and we use ferrous sulfate and fumarate also very freely. Even ferrous bisglycinate is used sometimes. It is chelated iron, and I find it useful in women who are a little intolerant to the above. And The polymaltose complex in oral form trivalent iron I have not yet found in my practice, but the absorption bioavailability seems to be better. And this is the MOHFW guideline, which sir already said that 100 milligram with 500 microgram of folic acid, at least for 100 days in pregnancy and 100 days postpartum. So that is what is the Government of India guideline. And it's important that it starts as early as 4th month, even in the first trimester, and continues 180 days and continues 180 days postpartum. Okay, so the treatment with this oral iron can lead to GI side effects, and 20% will kind of drop out, and very few patients adhere to the 6 months treatment. And this playing around with the oral iron frequency, content, alternate preparation, all can be tried in mild anemia. But in moderate and severe, we cannot play around. We have to quickly go on to the next level of therapy. So the indication will be failure of oral iron, non-compliance, intolerance, late manifestation, malabsorption, bleeding diathesis, combination with recombinant erythropoietin in women with chronic disease, moderate to severe postpartum anemia. I find this a very useful indication. Contraindications are when there are no facilities for resuscitation, do not take it up. Please have a crash cart ready always, even though test dose is not recommended, does not mean that there cannot be hypersensitivity. Known history of hypersensitivity, first trimester, and if we already know that there is an iron overload. The treatment of intramuscular iron is very well recommended in the MOHFW guidelines. In fact, guidelines for intramuscular iron are more robust in the government sector. But then it faced a lot of problems. So today, even in the public sector, it has been replaced by iron sucrose mainly. But yes, iron ferric carboxymaltose also will find its way. The adverse reactions are there, but very, very rare with parenteral iron, 38 per million doses. And the high molecular iron dextran no longer justified. Other irons are now coming up. And this IV iron agents are spheroid particles with a core. This red is the core of iron, and this is the carbohydrate shell. And the purpose of having a carbohydrate shell is to stabilize the molecule and allow a slow release of the elemental iron. Okay, so this is what we are familiar with, all of us, parenteral iron, and this is what we have used. Iron dextran as postgraduates, all of us have had experience of anaphylaxis and dealing with the anaphylaxis also. I still remember one instance, two instances, one intrauterine demise due to a blood transfusion reaction, one intrauterine demise due to an iron dextran injection. And when I was a first or second year postgraduate, I'm not remembering. Those days, it was very prevalent. Anemia was very prevalent. Iron sucrose, multiple doses, longer time of administration, yes. And this is the advantage of ferric carboxymaltose is large amount of iron can be given in a single dose. So let me quickly go on to the molecule in question. If we can see here, the properties of the ideal parenteral iron, molecular weight 150, okay. Complex stability is high, half-life is 16 hours, pH is neutral, isotonic, low antigenicity, no requirement of test dose, and time for injection is 15 minutes for the 1 gram, okay, and maximum dose, of course, is 1 gram per infusion per week, okay, not more than that, okay. So then the sucrose molecule has been with us for some time now. Many of us have been giving it as a slow IV infusion. Even today, for cost constraints, sometimes we choose iron sucrose instead of the iron for the other one. Okay, the ferric carboxymaltose, because that is slightly more expensive than this, and the total cost becomes really high. So the dosage pattern, okay, you can see alternate day therapy. Okay, in a day, infused over 30 minutes. If it is a slow IV infusion, which is, I do not give injection, so I'll not speak about it. It's diluted in 200 ml of normal saline and it's given. Of course, the Ganzani formula is 2.4 times into the deficiency of deficiency of hemoglobin. And then I add 1000. I don't add just 500, I add thousands, especially if it is moderate to severe anemia. So this is the molecule in question, very robust, not associated with hypersensitivity, higher dose, short infusion time, slow release. Although the infusion time is quick, in the system, there is a very slow release. And similar to ferritin, easily assimilated into the reticular endothelial system. Test dose is not required and low immunogenic potential. Okay. Dosage calculation is like this. I've spoken about the Ganzani's formula already. And hemoglobin less than 10, the average requirement can be this much, and more than 10, it is about 1000 milligram. Okay. Rarely we give for more than 10, but nevertheless, this is the chart which shows. Okay, so this is speaking about the 500 milligram and the 1000 milligram Orofer FCM. 6 minutes for the 500 milligram and 15 minutes for the 1000 milligram. 100 ml saline for the 500 milligram and 250 ml of normal saline for. So this is actually important because I think the stability of the molecule depends on the quickness of the infusion. And much as we would like to give it slow for the first 8 minutes, because I can't get rid of that habit even now, and then quickly complete it, it may not be what the recommendation is. So ideally speaking, it should go uniformly in 15 minutes. Okay. So this again speaks about the core and the surrounding. This again speaks about the content and the evidence available, the Indian clinical evidence for ferric carboxymaltose. Okay. These are the studies. I think we can add few studies from St. Philomena's Hospital. Only thing is we have not been proactive in publication, but we have done some 3 studies, 2 in postpartum anemia and 1 in antenatal, and it has given us good results. So to quote a few, this is by AIMS, I think. I can see our friends, Dr. Nirja and Dr. J.B. Sharma there in the author list, and 100 pregnant women. Rise in HB from baseline after 12 weeks, very satisfactory. FCM scores here. Okay, then we have the same one treatment with the same study. The mean rise in HB at 12 weeks was significantly higher. Okay, then we have this study by Gupte sir at his hospital, I think, and his team, 271 pregnant women, significant increase in hemoglobin percentage as early as 20 days. Okay, then we have the same one, no adverse effect. This is important. Perinatal or neonatal outcomes in newborns of women who received FCM during pregnancy. You can see all the outcome variables, all are looking quite good. So single large dose administration, rapid rise, favorable safety profile. So it is a preferable option. Okay, then this is something, these are something which speak about the comparison with iron sucrose, and this speaks about a tertiary hospital in Spain where anemic pregnant women received this. Okay, and all right. So for ASAP was done. This is a publication from Journal of Perinatal Medicine, and intravenous FCM 1000 to 1500. No complications were associated with FCM treatment of the mothers were evident in the newborns. Okay. And a 3-arm RCT. So this is of interest because it's an RCT, prospective RCT, single dose versus single polymaltose, which we have not used in India, or daily oral ferrous sulfate in the treatment of iron deficiency. Now, we do not know in this cohort what was the degree of anemia. Nevertheless, they may not have been severe anemia, but they were followed up till delivery, and FCM administered did not affect fetal outcomes. So this is establishing safety, perinatal safety with an RCT, which is valuable. So studies like this will strengthen our prescriptions. So this is Anemia Mukt Bharat, something which Arup sir was talking about already. And the first level of treatment, of course, oral iron is tried and only 2 tablets. So they double the prophylactic dose and they give for 6 months, and it is expected to correct mild and moderate anemia. Parenteral iron considered as first line who are detected to be anemic late in pregnancy, that is the government recommendation, or in whom compliance is likely to be low. And this is something which a clinician should judge and the team should judge. because this, by the time we identify lack of compliance, it should not become too late, and we will end up in transfusing blood instead of giving iron. So please see to it that this gets detected very early. And also those women who get lost to follow up, it's better to give them the injection and send. If no improvement after the above treatment, then we can manage this with intravenous iron therapy. Severe anemia, however, as I have, this is on severe anemia, the Anemia Mukt Bharat guideline says that treatment should be done using parenteral iron by the medical officer. And here I think the ferric carboxymaltose will have a very good safety profile and efficacy as compared to iron sucrose, especially the convenience of single dose. Now, this is the flow chart from very easily available on the net and very simple to download and keep with us. A 2021 publication from the International Journal of Hematology. And let me come right down here. Less than 4 grams, of course, better to give transfusion. And if there is no hemodynamic compromise, screen for hemoglobinopathy if possible. And then if they are in the first trimester and the hemoglobin is more than, even with severe anemia, this 4 gram, it's possible to have an oral correction and check the compliance, and then quickly switch to, if there is no response, then switch to other therapy, like checking the serum ferritin and then going on to intravenous iron. In the second trimester, if they're more than 7 grams, we can start oral, but less than 7 gram, checking further investigations like ferritin and going on to IV iron will make a sense. And in the third trimester, so this is pretty much what we do, except for the fact that every time we may not check serum ferritin if we are quite confident about it being an iron deficiency anemia with the peripheral smear examination and the red dices, etc. So that is a matter for discussion which can come up now. And in the third trimester, of course, if it is more than 36 weeks and the hemoglobin is less, transfusion of packed cells is the best course. But if it is more than 7 grams, again, there is a role of intravenous iron, even if she is close to term. So let us remember that, moderate anemia, near term, parenteral iron again has a role, because there is a little time and she can build up safety levels hemoglobin at least 10 grams before she goes for delivery. So that is what it tells us, the indications for transfusion in pregnancy with iron deficiency anemia. And I think I will safely skip this slide because all of us are familiar with this. Is it preventable? The answer should be yes. But well, it depends a lot on the health-seeking behavior and the health-conserving behavior of the population or to which we are catering. So it all depends on what is their basic nature. The women who come to us, are they ready to change to healthy eating habits and ready to spend a little more on healthy food and less on other non-essential things? That is what we need to find out. And we need to guide them for the good products which can contain iron, both vegetarian and non-vegetarian. As I said, diet is a different parallel, cannot be covered in a 20-minute talk. So the latest concept is, I was not able to get evidence to support, but this was supplied by the supporting industry partner. So I thought it is my duty to put that FCM is a nanomedicine under the category of non-biological complex drugs, NBCD. And the physical nature of nanoparticles make very efficacious and low labile and high cellular uptake and safe administration of high dose and rapid rise with safety. And 7 critical quality parameters of pH, osmolality, molecular weight, polydiversity, particle size, carbohydrate content, and the zeta potential. So that is what it is. So IDA in pregnancy, readily manageable and remains unmet health demand. That's what I said, that it is a public health issue also. The management strategy on the every each one of us know that it depends on the period of gestation and the severity. Widespread implementation of preventive and therapeutic strategies still lacking in our country. Foxy has done amazing efforts, state body, and even Bangalore Society has done amazing work in this field, but yet lot more needs to be done. Organization of camps, okay, patient group meetings, and the use of social media. I really like the thought of social media, and using a pragmatic approach that combines the recent scientific knowledge with an empathetic attitude of medical fraternity. That is important. Because many of our women do not understand the impact of anemia and the effect it has at the cellular level. The country can achieve the 2025 global nutrition target of 50% reduction in prevalence of anemia in the reproductive age group. Maybe we can achieve more than that. Well, thank you very much for a patient hearing. I'll stop my share and let us open the platform, and let me begin with your thoughts first. What are your thoughts on whatever I spoke? So let me begin with Mala or Pradeep, whoever is ready first. Yes, Mala.
Yes. No, I think that was a good presentation, Shobha. And I know we have all been using FCM molecule, and there has been concerns about its recommendation in pregnancy. And non-pregnant patients, no doubt it is a wonderful thing to use. And during pregnancy, as you pointed out, that it has got FDA approval now in the second and third trimester. Yeah. Obviously, the first trimester, we would not risk it. But there were some concerns about the fetal kidney, if its effect on the fetal kidney when used in the second and third trimester. There are not many publications on it, but I would like to bring your attention to it and see, if any other expert wants to comment.
Sure.
And my other concern was, of course, although they say that the risk of major anaphylactic reaction is less than 1 in 10,000 or even less, but there have been reported serious reactions with the molecule. And I think at such a platform is where we can share our individual clinical experience.
Absolutely, yeah. Any particular incident you would like to quote, Mala, please?
So, yeah, I have not experienced it myself, but I don't have the largest series of treating anemia parenterally because I'm an IV specialist.
Yeah.
But I have had a close friend who had a death in a nursing home, and she shared it on a platform, and it was FCM. And I just wondered if anybody else has a similar kind of, I mean, it's very difficult to go back and check what other things could have gone wrong at that point. But since, giving it fast is not an issue, because they do recommend that you give it over 15 minutes, and how much faster could you have been giving it to cause a reaction? I think that is not the concern.
That is not the concern, yeah.
But obviously, it is something we need to make each of us aware so that we can safely use it. Your guidance, absolutely, that it should not be given in a facility where resuscitation is not available.
Not available.
Giving it in a clinic is totally out of question. It has to be in a hospital where there is support from physicians as well as support for resuscitation.
Any positive experience in
their hemoglobin faster, because within a month they lose that hemoglobin again if they have one more heavy period. So it is a very beneficial molecule. And in the medical setting, in chronic renal disease, we have used it extensively in the medical setting, in the gynecological setting. And I really personally like the molecule because it gives such a good rise in hemoglobin.
Correct. Thank you, Mala. I'll get back to you very soon. Dr. Reena has raised her hand. Dr. Pradeep, if we can take Reena's comment and then to you. Thank you, Pradeep, for your patience. Yeah.
Thank you, Shobha and ISOPAP team for having us all here to interact. And first of all, I'd really like to support what Shobha said at the outset. We do a huge amount of work, but we don't publish enough. And I would like to say right here that I probably have more than 1,000 patients who have received iron in pregnancy. One study has already been published, It is approved by the ethics committee and it was used in the second and third trimester. And I genuinely believe that FCM is an extremely useful molecule. It is something which we should use liberally because, as they say in the FDA guidelines, if you think you need to give 1 unit of blood, think again. And if possible, you must avoid blood transfusion as far as possible. And that is the policy. And injectable iron is something which is really the way forward. In fact, I remember years ago, before the NACP 4 guidelines came up, our own past president, Dr. Mahapatra, had published a wonderful study on injectable iron, 3 doses given prophylactically, which reduced the need for blood transfusion and improved the morbidity and mortality. And this is something which I feel our NACP 4, you brought out the statistics very nicely. Your presentation was really detailed and it was very good. One thing, in fact, I would like to highlight, I was part of a public health program for Maharashtra where we were talking about prevention of anemia and how far our programs have worked. What was found, the only statistic which improved in the NFHS 5 was a marginal reduction in pregnancy anemia. Everything else, adolescent, postpartum, non-pregnant, the anemia statistics are dismal. Means our oral iron program, WIFs, or what the National Deworming Day, other things, although they are being done, are not really working, which is why we have to change the strategy. And that is where the parenteral iron comes in. And one last point I'd like to say, Dr. M.B. Agarwal, a very well-known hematologist, has also said that you can give up to 1,500 as a single dose in non-pregnant women. In pregnant women, I
have also read that, correct.
But otherwise, in non-pregnant women, where it's really been required, we have used 1,500 milligram as a single dose also.
Rita, before I move on to Pradeep, I just want to know one, do you have a lower threshold for intravenous iron as compared to the guidelines? I mean, do you kind of use it earlier than what is recommended, or you sense that the woman is totally kind of, going to benefit better than waiting? Like they say earlier in pregnancy, try oral iron even for severe anemia. So do you prefer intravenous? That's what I'm trying to come now. Say second trimester, okay?
I'd just like to say one thing that, most of the guidelines, even we often follow, we are part of the RCOG, I myself am FRCOG, but they keep emphasizing that local adaptation of your guideline. So even if we have a national guideline, we have to locally adapt it to the situation in your institution and in that particular patient. So here I feel is the importance of clinical judgment, which in fact will never be replaced by the artificial intelligence everyone is going gaga about right now.
I agree with you.
I feel here we need to apply our minds to it and see the situation. Is this a compliant patient? Do we have any other comorbidities? Are there any other factors? And then take a decision. Perhaps earlier in the second trimester also, you may use the injectable iron rather than wait for oral iron to work.
Yeah, I agree with you. If it's a high-risk pregnancy, in some way, you want to correct the anemia very quickly. Thank you so much. That was a very valuable input, Reena. I'll get back to you in a short while.
Sure.
Uma, I saw your raised hand and then lowered hand. I'll just take Pradeep's input and I'll come to you. Thank you, Pradeep. Can you tell about critical care and severe anemia in women and how do you...
Thank you, Dr. Shobha. So thanks for having me. So greetings from intensive care for all the August audience in obstetrics present here. So I remember Dr. Shobha having chat with me regarding use of IV iron. So we use a lot in intensive care. And in fact, the discussion surrounded around whether we've had any serious reactions to IV iron. So in particularly the carboxy maltase. So I have not had any sort. We use quite a bit because we get a lot of CKD patients and a lot of our elderly patients and even obstetric patients who come with post-bleeding or postpartum. So we do iron studies and I have not come across any reaction. So we use ferric carboxy maltase quite regularly for these patients. And if I look at the evidence, it looks quite compelling and very good presentation by you, Dr. Shobha. So you went through all the literature. So it appears to me that there is a compelling evidence of significant benefit with the use of iron formulation, especially in improving the iron stores or the ferritin stores, even in the postpartum, and most importantly on the neonatal outcomes as well, because There was one very recent trial in 2023, a big one, where they showed a significant sort of a benefit with the neonatal weight gain as well, and the ferritin levels also, which were significantly higher in the postpartum. And when I was looking into the literature, it appears to me that you need about 1 gram sort of a iron replenishment in pregnant ladies, because there are 300 to 350 milligram that is needed for the fetus
Yes.
and the placenta, and 500 milligram for expansion of maternal RBCs, and 250 milligram for the blood loss that happens during delivery. So there's pretty much 1 gram replenishment that one needs to have in pregnant ladies, which means we need to be little ahead of rather than chasing the hemoglobin, possibly we need to be little ahead in trying to replenish the lost stores. So it seems prudent that iron IV injectable format of carboxy maltase has a significant role to play, and possibly it should be included in the guidelines. As I could relate to your presentation that it's still not come in Indian guidelines. Maybe it's for
Not
societies like you
directly.
guys,
Yes, not
yeah,
directly. Yeah.
to have this as
It
a
is
part of
there.
a standard guideline.
Yeah, it is there for severe anemia, as a measure, but still, I think it is not very robustly driven by the government. That is
Yeah,
what I have got the
yes,
sense. I've been talking to others in the public
yeah.
health sector. I just want one input from you before I move on to Uma. And I am very happy that Meena, as the host, is supporting me. Will be there to be the last responder in the first series of questions. Dr. Pradeep, I just want to know, when a woman is very sick, critical care, has lost a lot of blood, and very often, these women will have some amount of chronic inflammation going on in their bodies, and sometimes there is an overlay of sepsis. So these are situations where iron ferric carboxymaltose can be a tricky drug to use, and the ferritin levels do not help us. So have you come across such situations? And
Yeah.
yeah.
So can I just show one algorithm which we tend to use in critical care, because that's a very pertinent question you asked,
Please.
Shobha, because ferritin is what you were emphasizing during your presentation.
Yes.
That is something that you may not be able to rely in critical ill. That's a very good question, which possibly is one that is related to my topic. I'll just show you the algorithm that I follow,
Please share
that
this.
we follow in intensive
Yeah.
care. Just
Host,
try
please
to.
enable Dr. Pradeep to share, please. I think you'll be able to share.
Yeah, you're able to see my slide?
Yeah, not yet, but screen, yeah, we are seeing it, yes.
Okay. So if you look at this particular algorithm, so we have iron deficiency anemia. So we do iron studies, and when we do iron studies, we look at ferritin, as you rightly said. So ferritin may not be very representative in our intensive care if suppose they have a sepsis or other infections. And so what we do then is we look at transferrin saturation. So if ferritin is low, then your iron deficiency is confirmed. So you said 30 is the cutoff. For other non-obstetric, we take as 45, or less than 15 is severe. If there is less than 45 with comorbidities, with evident anemia, we take it as iron deficiency. This is easy. But in ICU, if ferritin is normal, that is when you have a question. So when then we have to depend on transferrin saturation. So we look at the transferrin saturation. So if for transferrin saturation, if ferritin is normal or high and transferrin saturation is low, then we take it as it's iron deficient. So if it is S, then we take it as iron deficiency confirmed. If transferrin saturation is not low, then obviously we treat. If transferrin saturation is not low, then we need to look at other tests, like we have to look at hemolysis or other conditions to look at iron deficiency. So this is something we follow. So transferrin saturation is what we rely on in ICU if ferritin is something that we cannot depend on, Dr. Shobha. So that's the algorithm we tend to follow in ICU.
That's wonderful input. Dr. Uma, I come to you. Dr. Pradeep, if you're there for another 15 minutes, I'll be grateful so that I can
I'll be around.
Thank you so much. Thank you. Dr. Uma, I just wanted you to come into the flow. Of course, you are also from the Royal College like Mala and Reena, but you have an exclusive obstetric practice and of many years. I wanted your kind of, ground realities from your practice on this molecule.
Thank you very much, Shobha, and thank you for the invitation. Actually, You know, if you look back from maybe 20 years ago to now, I feel we're seeing more anemia now than we saw 20 years ago. I'm not sure what the reason is, especially when the practice is largely, urban, and it is a middle class to upper middle class population. We're still seeing a lot of anemia. So that is a point of concern, and I think that's reflected in the national statistic as well. And in every conversation around anemia, we are saying we don't seem to be making a difference. None of the programs are making a difference. So maybe our focus should be on the adolescent or the pre-pregnant woman to
Preconception counseling.
how, where what you spoke about social media may actually make a big difference. Because the reach is high, these FM radio programs and things like that. But having said that, like you said, couple of things that don't happen in practice regularly is to rule out hemoglobinopathies. Not everybody does that. And we also see a lot of coexisting B12 deficiency in especially in a purely vegetarian vegan diet, which is quite common. So I think it's important that we correct that. It's not uncommon to see low B12 and low iron, low ferritin when we are looking for evaluation of anemia that's not responding to oral iron, even when the woman says she's compliant. So I think, many times we forget the B12 story. That's just. And talking about, and the other thing that commonly happens in practice is we don't stop oral iron, we give ferritin. Now that again, it's with that ferritin load is given, should oral iron, when do we restart? Very often women are not advised clearly when to stop and when to restart. Now, coming to the question of reaction, one of the things that we know oral iron does, and actually Dr. Pradeep may want to come in on this also, is there is literature on hypophosphatemia caused by ferric carboxymaltose. And this is true, in the non-pregnant context in people who have CKD. We don't expect that in pregnancy, but we also know that we see a lot of women with low vitamin D, and not everybody is tested for low vitamin D. So I don't know the answer. I'm just raising it as a question that when you have a population where there is a very low vitamin D and we are giving a drug where they say actually the incidence of hypophosphatemia is fairly common as a reaction, though not necessarily resulting in anything fatal. I wonder whether we have all heard, a friend, a colleague who's had a mishap after giving FCM in the OP. Is it only anaphylaxis, or is there something else that we are missing? Because a lot of them are, a BMI of over 30 is not at all uncommon. So that whole combination, so is there a subgroup of women on whom we must be a little bit more careful about giving this iron instead of just doing it in the side room of your clinic? Is a question I'm raising to all of us, because ultimately safety is what we want, right? The trials show safety; they don't show a problem. All the literature does not show any problem with FCM. But the moment you hear a story and it's a colleague, you are scared to give. And I think that is what has been happening in the last maybe few months to a year.
Yeah, I get your point, Uma, very much. There was just one small thing which you tweaked and then you went ahead with the reaction thing. You said something about oral iron to be started very strategically. And I think the audience will benefit if you kind of elaborate on that. The oral iron, when to start.
No, because we're giving a ferritin load, and it's going to flood the system. So even if you take oral iron, your gastric absorption is actually going to be reduced.
I agree with you. Yes.
So we can actually stop it for a couple of weeks and then maybe after 2 weeks or so, or 3 weeks resume
Correct.
if we need
You
to,
know,
but
that's
ensure
very
we give them
interesting.
other
Very interesting point, because I have the same thought process. But when I have spoken about this on other platforms, then, you know, even senior logicians, they have told me that it doesn't matter. So it is better not to stop, because something which the woman takes every day, she stops, she may not come back to it. So that is why, and she may become complacent, because taking oral iron is not actually a very pleasant thing. So
But
we
but
have
we're giving
traditionally
her
been
this because the
problem,
oral
yeah.
iron has not helped up
Has
her
not helped.
hemoglobin,
Yes,
right?
yes,
So
I agree.
we'd rather ask her to substitute it with a
Kind of.
multivitamin if
Correct,
you need
correct.
to.
We are
But she'll have all the gastric side effects still and not have any benefit.
we are kind of, you know, going back on our own problems again by giving her
Can
oral.
me
I
and
agree.
Reena make a comment on this, Shobha?
Yes, yes,
Please,
please.
Mala.
Yes,
Definitely.
please.
Yeah.
Yes, please.
Go ahead.
Number one, a lot of pregnant women are on PPIs, and
Yes.
PPIs severely reduce iron absorption. And that is one of the reasons why oral iron doesn't get absorbed. And the UK guidelines on anemia state that you must stop oral iron 24 hours prior to giving IV iron and not flood the system, as Uma was saying, with iron. And I don't see the point of giving oral iron immediately either, because one of the reasons is its intolerance, gastric side effects. So why do you want to add that once you have given an adequate dose? And as somebody else pointed out, 1 gram in a pregnancy. So if you give her a 1 gram load in the second trimester, you're pretty much covering her second, third trimester and postpartum. And postpartum, you can very easily repeat the dose, because that is when the neonatal benefits come. If you give it just before her discharge, if she's had a PPH, the neonatal iron levels will be much better because it is going to be excreted in her breast milk. I'll wait and see what Reena wants to say.
Thank you for this very important point which you have raised, Uma. And we have had this discussion with hematologists, and they do say very clearly there is no need to give oral iron. In fact, it is contraindicated, and that is the policy we are following. But because in our country it is a dimorphic anemia in most situations, we in fact continue with the folic acid and multivitamins, not as a placebo effect, but that will help, and the nutritional supplementation.
Yes.
So that was the first point. The second point, what Uma talked about, is the possible anaphylaxis or possible life-threatening side effects of FCM. That should you be giving it as a private practitioner in the side room of your clinic? I can say that yes, I have the benefit of being in a tertiary care institute with everything. When we give the first dose of injectable iron, we need not admit the patient, but we make sure it is given under supervision in the side room or in the labor room side office. The first dose is given because you never know which patient may have a reaction. Although in that more than 1,000 cases, we have not had any anaphylaxis. The other question which Uma asked was, are there any other types of reactions? Yes, although the standard literature, and sometimes we get a little biased by the pharma inputs, but most of the standard literature do not describe any major side effects. But we have had the little bit of itching, flushing of the face, slight joint pains, but nothing life-threatening, fortunately, so far. There has also been a bit of controversy on sometimes, once in a while, when there has been a life-threatening side effect reported in the media with FCM. There was a medico-legal case in a non-pregnant woman where the issue of contention was that the serum ferritin level had not been done. So when you have a borderline case, or you feel there are risk factors, or you feel there's a problem, I think it was brought up in your presentation, Shobha, about role of serum ferritin. It is suggested that if you feel there is a high-risk patient or there is a bit of controversy, it would be advisable, and that wonderful algorithm showed by Dr. Pradeep has put it really very nicely into place. We need to use the serum ferritin to triage and decide if there's a problem, just in case something goes wrong. If you have serum ferritin documenting iron deficiency, you have done it in good faith. And even if things go wrong, which is a 1 in a 1,000 or 1 in a less than that chance, you are still on the right side of the law. So these are
I completely agree with you, completely. Dr. Pradeep, any input before I take up Meena?
Yeah, thanks. I think I wish to draw attention on Dr. Uma, what she said about hypophosphatemia, because it's an important sort of a molecule for our ICU people, because we are quite obsessive about phosphate levels. Because a severe hypophosphatemia can cause hemodynamic compromise, which means although you may be calling it as anaphylaxis, because some of the narratives that I've heard that someone has had a serious reaction to a point of dying, it means there must be either atopic individuals who have propensity for allergy, because we have seen reaction even to paracetamol. I mean to say anaphylaxis coming to my ICU following paracetamol injection. So any drug it can be a toxin for some individual who is atopic or who has a high sort of an allergic. So good history taking and hypophosphatemia, especially in someone where GI intolerance has been there, especially the discussion that you're all having about intolerant to oral supplements because of anorexia, vomiting, and they can be very depleted with phosphate already because of their GI losses. And in that situation, if ferric carboxymaltose has caused hypophosphatemia, that can lead to serious hemodynamic compromise, which is a very, very valid and important point to be kept in mind, that it cannot be negated as something which can lead to hemodynamic compromise or hemodynamic and respiratory compromise. So please bear that in mind, because any drug can be a problem. Because for me in ICU, everything appears safe, but for you, when you're administering these medications where there is no resuscitation sort of a
Not like
available,
ICU.
then it becomes a problem for you guys, because you will be facing a serious medical legal threat there.
Just one thing before I move on to Meena. In case you suspect hypophosphatemia as the cause of that allergic reaction or even drug reaction, how do you manage it or identify it?
In intensive care, any sick patients, we do a baseline phosphate, Dr. Shobha. So but I wouldn't expect you guys to keep doing phosphate levels for everyone, but any sick individual, we do baseline phosphate and we replenish it with IV phosphates are available. We have potassium dihydrogen phosphate, or we have oral phosphate supplements. We replenish, and in ICU, it's a norm that we maintain phosphate levels in a normal range. So because you might have heard of something called refeeding syndrome, which tends to happen in our ICU. Someone who is not taking oral diet adequately because of anorexia, and you suddenly you have a situation where phosphate level goes to suboptimal levels, it can lead to serious problem, Dr. Shobha. So that is something all of you can keep in back of mind. If someone is very nutritionally depleted because of whatever reason, and then this drug can cause hypophosphatemia, this can lead to a problem. I'm not saying it causes anaphylactic sort of a situation, but it can add on to the problem.
Just one more thing. Any other drugs have similar nature of causing hypophosphatemia?
In ICU, we do not have any specific drug that is known to cause. In fact, when I was reading about this, it came as a pleasant surprise that this causes hypophosphatemia. And it's a very important point Dr. Uma brought in. It's good for everyone to be aware. Even it was a revelation for me that this drug causes hypophosphatemia.
Thank you so much. Thank you. Dr. Meena, we come to you. Thank you for your immense patience, and particularly
I was enjoying all the discussions.
Yeah, I know. So was I. So was I. Meena, I think we come to, very, very grassroots obstetrics, and your and my work are similar. Both of us are attached to mission hospitals where women come in with a lot of anemia. Can you please give your experience and the research work which has been possible for you? Thank you.
Yeah, I think like everybody else's, our anemia rate is high. It would be around maybe 30-40% surely. And one thing that I insist on and we practice is in both first and the third trimester, we go for a CBC. Looking at all the indices is so important that there itself you get a lot of hints what's going on. And secondly, advocacy has been an important part during my chairpersonship, both for anemia and for thalassemia. And one thing, and not only here in rural and even bahar bhi, even going to the slums and all that. Then coming back to anemia itself, yeah, routinely we're giving Orlan, but then very often we do have the patient, this thing of complaints of intolerance, and many times they would opt for IV. And we have been using pericarboxymaltose. And in fact, it was part of a thesis of one of my PGs in the postpartum anemia, but not as a thesis in the antepartum period. And there were no major side effects in our studies. Only some rash and itching was there in 2 patients out of nearly 100 patients. Then regarding what you have been discussing about the anaphylaxis, in none of our patients, whether antenatal or postnatal, we've had that problem. But we've got 2 patients who have been referred to us with severe reaction. One was antenatal. She lost the baby. One of our senior gynecologists from Patna itself. She was in ICU for 2 days, and then she had to be delivered. Of course, she went into spontaneous labor thereafter. So, because she was a referred case, we do not know exactly what happened, but we were told no, after some time only, not the whole bottle had been transfused, and she developed that, and she was. So that was one case. The other was a gynae patient, another from one of our senior gynecologists. I think she had some menorrhagia or something, and so what she insists, the patient was not knowing very well, but the doctor said no, it was after FCM. So, you know what, at that time we also had a discussion after that. So they always say no need for a test dose. But the practice that you mentioned, initial few minutes, you give it slowly and then you push it. So I think why should we insist on, when off and on, sometimes or the other, some people can have some kind of reactions like this. Why not we remove that no test dose? Rather, we start with the slower dose, like you mentioned, that is out of habit. But then any drug we know can do that. So why not follow that? That is, that's come to our mind, and we've discussed about that. So to be on a safer side, that's one point that I want to raise. Then, what was your other question, Dr. Shobha?
No, I just wanted to know if you have any data to share, or would you like
Well,
to
I will. No, that
tell
was
me
enough.
any
Like,
success
yeah.
stories that you have been able to get very good response, etc. All that I
One thing
wanted
is
to know.
patients
Yeah.
are very happy to take it. Take one dose, and especially in the postpartum, because that was one part of a study. So they don't have to take iron tablets. Because we're giving at 10 hemoglobin and less. So that is the compliance, and they're quite willing to take. We did not have any major side effects.
Yeah.
And many of our patients who are not willing to take oral iron, even some of our doctor patients, they have been taking IV iron because of this problem, gastritis and having to take. And often some of our patients, and when they have gastritis, we would tell them that not to take oral iron every day, rather, intermittently, maybe alternate.
You do all that. Yeah.
That is.
We tried to trick the
Then
stomach, but we are not
success
very
has been
successful.
because it was part of the study.
1
we've
minute.
also
Dr.
been
Sharad, can you please mute? Dr. Sharad, you are required to mute, please. Yeah. First, please mute Dr. Sharad Lang. Thank you. Yeah. Yeah, Meena. Yeah.
So, because it was part of the study, we routinely did serum ferritin, and the postpartum, 6 weeks later, both hemoglobin and the serum ferritin level were found to be high. So that was one difference, though the oral iron the hemoglobin level was raised, but then serum ferritin response was better with the
as
IV.
expected. It will not improve that well with oral iron. Thank you, Meena, for that valuable input. The only thing is those reactions which you shared, probably, we need to be very sure that it is because of the drug. What you raised, the point was, I think, about the test dose. Now, I must share with everyone that, and even the industry partner individuals are here. I think the team is here, Shrikant and Mr. Bora, everybody. I just wanted to remind all of them that I have been consistently asking for provision of a test dose. And they have been consistently telling us back that there is no need of a test dose. So this is the kind of conversation which has been going on for the past years. Nevertheless, we have continued to use the molecule. we have also had our share of negative experience, but the positive stories are far too many to cast any kind of obstacle. And wherever we come across doctors like Dr. Reena, who has had large volume experience, a lot of patients in whom she has used, so that kind of makes us more convinced, and that gives us also strength, because we also use, but if it is a public health system where large number of women, or even a hospital where large number of women can be given, then that is very reassuring that there is no. But if the industry partner can introduce a test dose, then I'm sure this molecule will at least double its application and its utilization. So do the experts feel like that, like I am feeling? Let us start with Mala, then Uma, Reena, and
Well,
Neema, and
I
then
think that depends on whether how many of the reactions are truly anaphylactoid. If there are biochemical disturbances, and then obviously the test dose will not prevent those. But yes, it seems like a good idea. I think you certainly can't lose anything by giving a test dose, because the atopic individuals will certainly be caught in that net.
yeah. And then I think in OB-GYN practice, when it is centered around pregnancy, the stickiness doesn't go away. If one adverse event happens, and that is what happened to us also, and it just sticks, like one IUCD perforating the uterus, then a whole population says we don't want IUCD. That is my contraception experience. So similarly, one adverse reaction, and women immediately get alerted, and they say, no, this injection will not do for us. So a very valuable drug, a very potent drug, loses its chance to make a difference. So that is what I was trying to get across to them, that you please help us in this. See that in some way we can have a kind of test dose opportunity, so that we can really increase the strength of this prescription.
Yes,
Uma,
as you
you
said,
have
the vial is expensive and you can't open it and make a test dose
yes,
out.
we cannot. They have to provide it separately, as Jectofer had, the intramuscular one, as that used to have a small vial which we used to give as test. Uma, anything on that, and any other input? Because I think it is time to take conclusions by everybody, much as we would
So
like to chat on.
A test dose is a good idea. However, my understanding, and I may be wrong, is if it's anaphylactic, it can happen even with the test dose. So we have to be careful. We won't open the big vial, but if it's truly anaphylaxis, test dose is enough to cause it.
Yeah,
But
but then
the fact
the
that there
volume
is a
will be
test
less to
dose
contend with. No, the volume will be less to contend with.
No, and I mean, we will be seen as taking a safety precaution.
Yes.
That visibility will be there, but I think we may still have to be prepared for that.
Yeah, that is what
See, the
Mala
thing
has
is
also told.
like Reena said, if it happens in the labor room, we will have the wherewithal and the manpower to begin the resus as it is required. May not be as comfortable as an ICU, IMCU setting, but at least the manpower is there. In an OP setting, it becomes a challenge. And I think that casualness may be, because the patient also perceives it as like, I'm coming to take a TT and go away.
Yes.
So maybe we should counsel that there is
That
a
is what is
possibility, but
important.
the reaction it's very low.
Yeah.
And therefore, we will give it in a supervised setting. So they also understand that this is a drug, a potent drug, which they need. It's not like coming and taking, immunization, for example.
Correct. Yeah. I agree with you, Uma, because when we counsel for VBAC, remember, that's what we tell them. It is very rare to have scar dehiscence, but it's a rare complication, but it's a major complication. But the problem with therapeutics is the moment we say that, they take a step back and they say, okay, we'll settle for blood transfusion, or they will say that, something else. So therefore, this is not an easy, yes, but I mean, from their perception. I just want to ask this question to Reena and then to Pradeep, because we have absolutely no doubt that this molecule is good in its efficacy and does wonders for the woman, whether she comes for ops anemia or gynae anemia, it does wonders for her. All of us are very convinced. If we are to use this, what kind of preparedness we must have to tackle hypersensitivity? What does your crash cart looks like? Do you want to talk about it? A crash cart being ready in the labor room or in the ward where this is being injected? So, Reena, and then Dr. Pradeep, yes.
Yeah. So, Shobha, your first question was that do you think we should add a test dose as a mandatory requirement? I don't agree with that. We just have to be very sure. One of the biggest advantages of FCM is that you give it in the same sitting. You can give the first little bit slow and then you continue. So I would not agree with giving a test dose. It's just that you have to be prepared and give it under supervision.
So stand there and,
yes,
a trained person who's trained in giving this stands
so
there,
that is the
gives,
key. Yes.
Correct.
That is the first thing. And the crash cart, which should be actually checked, and the expiry date of all the drugs checked regularly, because often the crash, and if it is used, it should be replenished. That should be in every area where you are possibly using. It can happen in the ward. It can happen not just for this. It can happen with anything.
Anything.
In that, your basic things for the ABC, the airway, breathing, circulation, what you need for the support, the drugs, the syringes, the needles should be properly kept and labeled. There should be one sister should be given that duty on a regular basis to be checking if all the items are there or not. It's not just the ampules and the medication. Simple thing like a ampule cutter, having the correct size syringes, and also having a IV line and an airway in that crash cart, because you are not expecting it. Even an MBBS doctor, like the interns, often you find that the interns are the lowest in the food chain. And although we have given strict instructions, even the blood should be checked and started by residents, you often find it is the lowly intern who is doing all the work. And then if something goes wrong, they are sometimes confused and don't know what to do. But as MBBS doctors, they should be trained in basic. In fact, now it's become an NNC requirement that before the basic resuscitation training, the basic life support information should be available with all of them. So I think Dr. Pradeep will be a better person to give us more information on this. But I feel as obstetricians, we cannot say that we are only going to be looking below the belt.
Yes, correct.
So we have to be prepared.
Must be trained in this.
And the most important thing, there's a saying, the eye does not see what the mind does not know. Correct. You have, in Girl Guides and Boy Scouts, the motto was be prepared. If you are prepared, you can do anything. You can manage the worst complication. But if you have a simple thing like the oxygen cylinder in the ward is empty and the patient has collapsed, then you are liable, because it was something you should have looked into it. If your central oxygen is not there, the cylinder should be available for resuscitation. These are just simple examples. But here, the thing of having a checklist and having regular quality control in your SOPs is the way forward.
Wonderful. 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 Yeah, Dr. Pradeep.
Yeah, very well articulated, Dr. Reena and Dr. Uma as well. I agree with both Uma and Dr. Reena that test dose is almost a misnomer in ICU, Dr. Shobha, because I know you emphasized a lot on test dose. Because I'll give you an example. So we have a snake bite. Almost more than 50% develop reaction to anti-snake venom when we give it. But it doesn't mean we stop giving ASV, because that is life-saving. So we have tools to circumvent the reaction that they have, and we need to be prepared, like Dr. Reena so very well emphasized on that all the obstetricians, I know in all your conferences you do obstetric critical care workshops, a simple sort of a checklist measures that needs to be put in place. Have a IV bag in place, and have an adrenaline, and have a antihistamine and a steroid, glucocorticoid. These are the only drugs we use for any anaphylaxis that happens. And immediately what happens and oxygen, of course. And immediately what happens in any sort of a reaction is they tend to get hypoxemic and they tend to get hypovolemic, their blood pressure drops. So what the need is simple. These are the only 4 drugs that even in ICU that we would be depending on to save a life. So have adrenaline is the sort of a lifeline in any anaphylaxis, because what they need is adrenaline, then a steroid, then an antihistamine, and an oxygen. This is all you need. So a preparedness to this effect and having some sort of an emergency cart. I would expect a crash cart seen in a tertiary referral to be present in your clinics. But having these four tools may not be too much of an ask, I would imagine.
Yeah.
And I'm sure many of you who have trained from abroad, you all have adrenaline jets that people carry, even some who are having propensity for anaphylaxis. So it's about time that you all keep adrenaline as a resource, and this is all we do. And you
Yes.
can do that initial and then shift the patient. So that would be my submission. But test dose will not save the problem, Dr. Shobha, because
Okay.
as Uma
Okay.
rightly pointed out, test dose itself can cause severe anaphylaxis many
Yes.
times.
Yes, yes, yes. So that was a message very well discussed. I think a lot of gynecologists today have understood that, when they say that no test dose is required, they don't mean that no reaction will happen. Reaction can always happen. So that inference we should have, and we should be prepared to deal with drug sensitivity. Dr. Meena, any closing messages from your side? I think we have discussed at length. Yes.
Yeah, I think we have. And yes, IV iron is there to stay because there are definitely a section of, especially in pregnancy, who would be needing them because we
Thank
have
you
a
so much.
limited time and the intolerance part is there.
Correct. And in ISOPARP, how should we kind of bring in screening for anemia and thalassemia? What do you feel? If you can be a little
We have it
comprehensive on
there.
this subject. Yeah.
So we do have it starting with the first visit CBC, and I was a thalassemia, especially those who are anemic and where the microhypo is there. So because many a time they go unnoticed, and it's only once the baby is affected or you have somebody in the family, then you go about looking for it.
Correct.
But then because in the last 2 years we've done it routinely as a part in this region to look for the prevalence, and it's not that this part is not, it's not devoid. We do get, though we not analyze, but very often we keep finding one in the family, and there's no history, and yet they turn out to be carriers. So I think that also, again, if somebody is not responding to the kind of simple iron therapy, we must look into that. And
I
because the
do
family,
think in the public health sector today there is routine screening for thalassemia. Is it there? Or
we are advocating, we are doing it, yet not
yet.
everybody, like there's some reasons, the pockets where the incidence is very high. Because in, I think, South, they say, because I had a talk with the Charmila, she says, no, it's not part of our routine because the incidence there is pretty
No,
low.
not definitely. Only as you said, when they kind of do not respond well and they remain mild to moderate anemic for a very long period of time, then we suspect and we immediately do. But today the threshold for doing thal trait testing is much lower than it was earlier. We all understand that it is more common than we initially thought. So thank you for those valuable inputs. Closing comments from Mala and Uma, because you spoke some time back, and then I think if anything, Reena and Pradeep want to add, I will deliver the vote of thanks. Mala, did you enjoy this chat show, Mala?
It's really good. Thank you, Meena, for your input and for having me here. And thank you, all of you, for this wonderful discussion. We learned a lot. And I think this thing that it has FDA approval for second and third trimester, I think is something which is not common knowledge in the gynecologist circle so far.
Thank you, Mala. That is wonderful. Uma, would you say anything for
I think,
the molecule?
So anemia is a serious problem which we still have. The complications from anemia at time of delivery are quite significant. So the fear of an adverse reaction should not stop us from using FCM when it is appropriate and to the woman's benefit. I think we need to counsel and be prepared for that, for a potential adverse reaction. As like most of us in our own practices, we have not seen it despite many years of use. But but that's true of anything in medicine, isn't it?
It
It's
is
always
true.
likely to be an
Correct.
adverse
It is
reaction
true.
to something.
It
We
is
just
true.
need to be prepared and
Yeah.
use it appropriately.
Yeah. If I just may add a small comment here on the adverse reactions shared by everybody, including what happened in our hospital. I feel that if standard SOPs are in place, as so well elucidated by the experts today, for managing the hypersensitivity reaction, then I think the outcome would have been far more favorable than better than what we experienced. But we need to keep in mind that the benefit or the right part of it is very huge. The benefit of this molecule is very huge, and we must always keep that in mind. Reena, last words, and Pradeep, last words, and then we close. Yeah, unmute.
I think this has been a very interactive and wonderful session, but I feel the 2 or 3 key messages that we should take home today are that do not hesitate to use injectable FCM. Do not persist in giving oral iron. You will have more problems with that and it defeats the entire purpose. And don't be afraid to try this. But again, important thing is go for good quality medication, because there's been a lot said about poor quality ampules, or when you go for generics which are not from a standardized company, that can be associated with poor reaction. We didn't have time to discuss that aspect, but I feel this is something also we should keep in mind. And you know, there's a saying that if you give peanuts, you will get monkeys. The same thing applies in healthcare. Why is there a difference in going to a roadside shanty where one person with some various string of degrees against their name is there, and as per going to a tertiary hospital? It's because you are wanting quality of care. So let's keep the quality of care
Yes.
as good at whatever level we are working. Thank
Those
you.
are a little kind of, you know, slimy waters to tread. So I did not mention the molecule, but then a point well taken that one should look for time-tested drug. One should look for time-tested drug, and all of us have been practicing for near about 30 years. We all know with our experience that, you know, what has worked for us in the past, and we shouldn't lose sight of that. Pradeep?
Yeah, thank you, Dr. Shobha, for having me. And it was excellent discussion and very nicely moderated by you. And I learned a lot of lessons. So the key thing that I learned today was the point that you made, Dr. Shobha, that anemia has an attributable mortality of 18% and 20%. And that is a very striking thing for me. If that is what it is, which is the attributable mortality, we need to be ahead rather than chasing the hemoglobin or iron deficiency anemia. So in ICU, we don't chase things. We need to be ahead of things. So please go ahead, and I think you should use this iron, obviously keeping all the SOPs in place. And we are there to help you. Intensive care is always there to save all your patients. So I think you should go ahead and be ahead rather than chasing the whole iron deficiency. You should be ahead by using this beautiful molecule. We have been using it a lot, and we have not had any reaction to this.
You know,
Thanks,
Pradeep, I'm
Dr.
so
Shobha.
happy that I got you into the expert list. That was a very positive
I
message.
think I'm the only odd man out in this
No,
whole
no,
obstetrics.
you're the right man in. You're the right man
in, yeah.
You have given
Thanks
us
for
the
having me.
strength. Yes. No, but basically, I think fundamentally, obstetric care in itself is some kind of critical care, because we will always have 2 lives, and there is nothing like a no-risk pregnancy. It's either a low risk and a high risk, and a low risk can rapidly transform into high risk in a matter of minutes or seconds. So that is the reason all of us must be very, very adept at all problems, and then it's better to train ourselves to manage reactions rather than be afraid of the molecule itself. That was the final message I wanted to give, and here is to wishing that women enter into pregnancy with less and less anemia, so that we have to manage severe anemia less, and we become experts at it. Thank you very much, all the experts. Wonderful inputs by Dr. Mala Arora. Thanks so much. And Dr. Reena Vani, absolutely wonderful. Uma, my God, your wisdom is belying your age, I think. I have very wonderful inputs. It stemmed a lot of discussions. Uma, thank you so very much. I can't see you. I think you are with a patient. I can't see you. Uma, please come on. We are ending the session. And Dr. Pradeep, as I said, the right man in. I think we must work more with critical care physicians and seek more help for our HDU settings. We need to have, and in fact, I sometimes wonder where molecules like this should be transfused in the high dependency unit rather than in the ward or the labor room, because then we occupy space in the labor room. It's better to have women like this in the ward because first of all, they are severely anemic, and second of all, we are giving them a parenteral iron. So maybe HDU is better utilized. Crash carts are always available there. So these are the messages we wanted to share with the audience today. Arup sir, thank you very much for giving me the platform. And, I'm so happy. Meena, you would agree that ISOPAB has had some useful messages today, don't you?
Definitely.
Yes, definitely. Thank you very much. So thanks everyone. And I thank our industry partner, the academic partners. Thank you, Uma. We just now said that your discussions really brought in a lot of value to the, to all the inputs from the other experts. So each expert has done amazing. I am so grateful. I'm grateful to Dr. Maji and Dr. Pragya Mishra for giving me the opportunity. And with that, we sign off with thanks to Mr. Bora for tolerating my, all my idiosyncrasies for the flyer. And Shrikant, thank you very much for being such a dear friend and always being there. Thanks, Emcure. Thank you. Signing off. Let us meet again on another chat show.